Onc Live Insights is a video editorial program produced by Onc Live.
Although patients most commonly present with localized disease, there are patients that can present with metastatic disease. As mentioned earlier, metastatic disease is most generally confined to the abdomen, with sites including liver or peritoneum or sometimes other sites of the GI tract. What is far more or less common is actually involvement of the lymph nodes or lungs, and this is generally considered to be unusual. And if a patient were to have lymph node involvement or suspected lymph node involvement or nodules in the lungs, it would be best to try and obtain a biopsy to determine if these are in fact related to the gastrointestinal stromal tumor or some other particular process. Now, in terms of the treatment for metastatic GIST at this time, the only approved therapies essentially involve tyrosine kinase receptor inhibitors. Radiation has generally been found to be a modality that does not induce any effect on these tumors. Based on several early phase trials conducted in the early 2000s, namely a phase 1 trial conducted in England, as well as the B2222 trial conducted at multiple centers here in the United States, patients with metastatic GIST received benefit with imatinib. Since then, there have been several larger scale trials to evaluate the efficacy and safety of this particular regimen, and it's now considered standard of care or first line to use imatinib at 400 milligrams daily for the treatment of metastatic GIST. Now, although it may not be common at all centers to do molecular testing, it is highly recommended to consider performing a mutational analysis on the KIT gene and PDGFR gene, as there have been at least one phase 3 study conducted by the EORTC that found that patients with KIT exon 9 mutations were most likely to benefit from elevated doses of imatinib at 800 milligrams a day. Importantly, if patients do develop resistance to imatinib, the most common next step is to consider either a dose increase of imatinib from 400 milligrams daily to 800 milligrams daily, or to consider a switch to a second-line therapy such as sunitinib. The decision to do this is largely based on discussions between the patient and the oncologist and a review of the potential side effects. Importantly, if a patient becomes resistant to imatinib early on, in other words, within the first few months of therapy, the patient's unlikely to derive more benefit by elevating the dose of imatinib. Otherwise, if patients develop resistance at 1 to 2 years, elevating the dose of imatinib may still have a result in efficacy for the patient. Once a patient has developed resistance to imatinib, the current second-line strategy involves the use of sunitinib. If a patient becomes refractory to second-line therapy, the third-line therapy is currently regorafenib. These are all FDA-approved medications. They're all tyrosine kinase receptor inhibitors, but importantly, they each have unique features. What we know about these medications is that the structure of these medications result in the ability of these medicines to bind to a variety of proteins. While it's most important that it binds to the KIT oncoprotein, we do know that there are other potential targets. This is in part what differentiates medications such as sunitinib from imatinib. Sunitinib and regorafenib, pazopanib, and others are known to bind with oncoproteins related to the vascular endothelial growth factor receptor, as well as other receptors, and we think this is in part why there's actually differences also with regard to the toxicities related to these medications.